Thank you very much. So my colleagues and I are interested in taking advantage of advances in machine learning approaches to better match depressed individuals to the optimal treatment. So depression is a huge problem worldwide. The World Health Organization recently ranked depression the #1 cause of disability in the world. That's not just the #1 cause of disability among psychiatric diseases. That's across any disease, period. If you look at the figure on the right, you can see that the WHO estimates that there are 322 million people in the world that are suffering from depression. In terms of percentages, rates of depression are low in childhood, about 1 to 3%, but they surge during adolescence. And by the end of adolescence, about 15% of teens will have experienced at least one episode of clinical depression. 800,000 people die by suicide every year. In terms of the US, these are 2016 stats. The suicide rate was more than double the homicide rate. So there are around 40 to 45,000 suicides in this country every year. Even in high-income countries, only about half of individuals receive treatment for their depression. We have a variety of different treatments for depression, different forms of antidepressant medications, different forms of psychotherapy. But in clinical trials of antidepressants, only about 50% of individuals respond to treatment and 33% achieve remission from their depressive episode. And that's in carefully controlled clinical trials. In real-world routine practice, rates of response and remission to first-line antidepressants are even lower. Also, 4 to 8 weeks of treatment are often needed to evaluate the efficacy of a given antidepressant and to contemplate alternative treatments, which results in protracted periods of depressive symptoms until an adequate treatment is found. Now, I should note that the modest rates of response and remission aren't specific to antidepressants. They also apply to psychotherapy. So to summarize, our treatments are pretty good, but they're certainly not good enough based on those numbers. So how do we improve outcomes for individuals suffering from depression? Well, one approach is to, of course, develop better and more potent treatments for depression. That's been a challenge over the decades. There's been some promising progress in recent years, though. Another approach is to better match patients to the treatments that we currently have. Of course, those two approaches aren't in conflict. We can do both at the same time. In terms of treatment matching in current clinical practice, treatment selection is based on trial and error, as well as other factors such as a patient's insurance and patient-clinician preference for a particular treatment. But in the end, you're trying one treatment, one antidepressant. If that doesn't work, then you try another, and so on. So an important question is, can we use data-driven machine learning approaches to better match depressed individuals to the optimal treatment on the basis of pre-treatment characteristics, clinical characteristics, demographic characteristics? We've also examined neurobiological characteristics. And we know that individuals with depression vary substantially in their responsiveness to a given treatment. So as one example, here's data from a clinical trial of the antidepressant sertraline, aka Zoloft. Every black line here represents symptom improvement for one individual in the trial. And as you can see, there's a lot of variability in treatment response, where you have some individuals who finish treatment with none or mild symptoms, so they seem to do quite well on Zoloft. Others finish treatment with moderate, severe, or even very severe levels of symptoms at the end of treatment. So many of these folks might be better suited to an alternative treatment. And to illustrate this, let's imagine that we have a clinic. To keep it simple, let's say that we have 2 treatments to offer, and there are presumably certain individuals represented in gray here who are equally well suited to both treatments. Others who are shown in white and in black here might be better suited to one treatment or the other. And the question is, can we use data-driven approaches to sort out these subgroups, to identify these individuals to give them the better treatment for them from the get-go? So we've been using machine learning approaches to predict treatment outcome and to inform treatment selection. Some of the benefits of machine learning approaches include that they can handle a large number of variables, in our case, pre-treatment patient characteristics, and they can generate predictions for individual patients, among other benefits. Our goals include the development of a patient-specific prognosis calculator. That is, prior to starting treatment, can we predict if you are at high risk of a good outcome versus high risk of a poor outcome, because that can be clinically useful information to have. And also, if you're at risk of a poor outcome, to identify the specific baseline characteristics that are increasing your risk of a poor outcome. Because depending on the characteristics, we could target it in treatment to enhance your outcome. And we're also particularly interested in trying to predict your outcome if you receive treatment A versus if you receive treatment B, because that can inform treatment selection. So I want to very briefly describe one example of a study where we used some of these machine learning approaches to try to identify, in this case, who needs an antidepressant, Zoloft here, versus who does just as well on a placebo pill. Of course, we're not comparing two viable treatments here. We're trying to identify prior to the start of treatment who needs the active ingredients of an antidepressant versus who does just as well on a sugar pill. So what we did is we randomly assigned patients to Zoloft and placebo. For our analyses, we separated our sample to a training and testing set via 10-fold cross-validation using a 90-10 split. So essentially, we're building our model with one set of patients, 90%, and seeing how well it performs in a new set of patients, the other 10%. We have a large set of pre-treatment clinical, demographic, and a few behavioral characteristics collected from all patients at pre-treatment. We feed those through several machine learning approaches to pare down the number of variables to a manageable set of significant predictors. We use that final set of predictors to predict for every individual separately your estimated outcome if you receive Zoloft and your estimated outcome if you receive placebo. Then we can use this last step to identify the subgroup that's predicted to do better on Zoloft. So those are the predictions. Now we can evaluate the utility of the model by taking advantage of the initial randomization of patients. So if you're predicted to do better on Zoloft, do you do better if you're randomly assigned to Zoloft versus if you're randomly assigned to placebo? So these are the individuals that are predicted to do better on Zoloft based on our algorithm. So what we found is, first, in terms of the full randomized clinical trial, this is just randomly assigning patients to Zoloft and placebo. There were no significant between-group differences in depression outcomes. That's not an uncommon finding in these trials. However, for those individuals that are predicted to do better on Zoloft based on our model, if they were randomly assigned to Zoloft, they did significantly better than if they were assigned to placebo. And this difference here is a four-fold larger between-group difference in outcome here compared to random assignment. So in some of our work, including the previous study, we purposefully excluded any brain imaging measures given that they're costly and time-consuming. We only wanted to include measures that could be reasonably integrated into a current psychiatric clinic as part of the intake pre-treatment assessment. But what is the added value of brain imaging for predicting treatment outcome? There's a variety of different brain imaging approaches out there. Functional MRI is very popular in psychiatric studies, but it's quite costly. EEG, shown here in the top right-hand corner, is a relatively inexpensive and easy to administer, non-invasive brain imaging approach. But one of the downsides of EEG is that it can only record brain activity that propagates up to the scalp. Unlike MRI, you can't really localize brain activity to a particular brain region, but we've used some source localization techniques to estimate brain activity reliably in one particular brain region, the rostral anterior cingulate cortex, or rostral ACC. And we found that rostral ACC activity, assessed via EEG, as well as the functional connectivity between rostral ACC activity and other key brain regions, predicts treatment outcome. And importantly, it predicts treatment outcome above and beyond the contribution of much less expensive and more easy to administer self-report clinical and demographic characteristics. So it's adding meaningful predictive value. And combining clinical, demographic, and our rostral ACC marker, we can account for about 40% of the variability in depressive symptom improvement. So finally, in terms of next steps, our work's been done in carefully controlled clinical trials with carefully selected patients. We're now testing this in real-world clinic. Rather than relying on a single algorithm, we're also doing head-to-head tests of different algorithms to see which one performs the best. And a critical test of a model is to see how well it performs in a new set of patients entering the clinic, which we're testing now. And ultimately, our goal is to implement an algorithm that would give the ability of real-world clinics to identify the optimal treatment for individual depressed patients that are entering the clinic. Thank you very much.